Ladies and gentlemen, Tony Heffernan, my name. Very quickly, I represent the Saoirse Foundation, a new organisation, only 4.5 years old, and what we're here to do is trying to bring some innovation to the field of rare and genetic disease. We operate a number of projects, as you can see there, Liam's Lodge, Beaver Battens and the Children's Ambulance, Bumbleans. However, my main focus today is basically on the present field of rare and genetic disease and information and credible information regarding e-care and empowering people at home to support themselves in looking after their children or themselves when dealing with a condition, from diagnosis right through to death in many, many cases, so they can have a better feeling of well-being. At the moment, there are severe risks, as the Minister and others have touched on, with just browsing the internet and social media and other web-based products where information can be scanty at best and definitely unreliable. So driving on to what I'm trying to do on behalf of the Saoirse Foundation is to develop something new, something that other people have tried to replicate and be part of before but never have got there in an e-care model. So what we need is a credible location for this information to be homed in on. So a resource that parents, patients and medical professionals can use and feed into. It's a partnership. So if we had a template where I find that as a parent or previous parent, my kids are dead now, but as a parent, if I had a place where I could get good information or a place where I could find how to do and how to do it right, just little notes, and if I could keep that on my phone or keep it somewhere readily accessible. But if we could develop a template together, so I'll be calling on people with skills with data, software, medical professionals to build a template, clinicians to feed in to try and extract from the parents and the patients as well the information that they can provide, so we can start developing data sheets. And by data sheets, I mean it's that when you're going through your life and you're working with the medical professionals who are supporting you and trying to give you a better life and greater well-being, that you can actually track the progress of your life as well as get the latest information on how to better look after yourself. So it's self-care, it's e-care, but also supported by medical professionals. So if I've left anyone out with a skill set that I haven't mentioned, please get in contact and join our group later. I don't mean to offend, but if we have something which is simple, a lot of people in here, and Evelyn said it, we all use social media, we all have smartphones now, we all know how to tag our favourite bookmarks and everything like that, but I think if we develop a template first and be able to source this information and then fill in a private way, you know, you have ownership, the patient and the parent have ownership of this as well, and they can put in data. Who knows how that data can be manipulated in the future into developing registries for rare and genetic conditions, which is our main focus. But that could be just modelled and replicated for other conditions. One of the most important things is working in collaboration. So you have credible links to organisations who are already the experts in their field. Let them feed into the same platform, so they become the moderators of a conversation between the medical professionals and the public, so that there is an engagement system where everyone knows, well, the people I'm talking to and the information I'm being provided or the data I'm collecting can be used for the benefit and public benefit, which is more importantly, and we all in the room have that in mind. It would also help to have podcasts and using existing technologies so you can show people. So if you're from I always remember my own personal story when I was told by my daughter to give her buccal midazolam. I was brought into a ward and I was shown a video for 2 minutes how to administer buccal midazolam. I wasn't given that video. I wasn't given a link to it. I wasn't given anything to empower me to do it properly at home. I was sat down on a chair for 2 minutes. So let's bring it back to basics. Let's create something new, and that's what we'd like to do today. Thank you very much.
Meningitis is the inflammation of the lining around the brain and spinal cord, and septicemia is the blood poisoning form of the disease. Young children and adolescents are most at risk, but anyone of any age can contract meningitis. Unfortunately, 1 in 10 people who contract meningitis and septicemia will die. 1 in 4 survivors will be left with lifelong after effects, and 1 in 3 meningitis B survivors will have minor deficits, including psychological disorders and reduced IQ. You can see from the screen that these diseases have far-reaching consequences for the patient and their family. Meningitis can cause brain damage, epilepsy, and deafness, while septicemia can result in amputations, growth deformities, and permanent organ damage. Some of the less obvious after effects of a brain injury may not become apparent until later on, so for example when a child starts school or moves to secondary school. So knowing what to look out for is essential. Although the mortality rate from acute bacterial meningitis has fallen in recent years, there has been no change in the rate of after effects. Ireland has the highest incidence of meningococcal meningitis and septicemia per capita in the EU, and that is why the problem we are here to discuss today is so significant. There are on average 200 cases of bacterial meningitis and septicemia every year in Ireland, and globally 1,000 people lose their lives every day to meningitis. With your help, we are hoping to find a solution to the lack of after effects information given to meningitis survivors and their families. This is particularly difficult given that the after effects are so varied and often only manifest themselves a while after discharge from hospital. People are often unsure what to expect after meningitis and septicemia. Parents of children affected tell us that discharge from hospital can be an anxious time because healthcare professionals are no longer on hand to answer questions. UK guidelines on managing children with meningitis and septicemia recommend that healthcare professionals give parents and/or patients who have been affected by the disease information about recovery, potential long-term after effects, and follow-up care before they are discharged from hospital. However, Meningitis Research Foundation has been working with families for 25 years, and in our experience, follow-up information is not always provided, and parents and patients frequently feel unprepared for any after effects that might occur and are at a loss as to who to turn to for the right answers. The feelings of some Meningitis Research Foundation members who survived meningitis also reiterate the need for clearly signposted, well-explained after effects information for patients and their families. Pauline from Portlaoise said, "When I left the hospital, I was told I would be grand in about 3 months. 2 years later, I'm still not grand. I was lucky not to lose any limbs, but the hidden after effects are very hard to deal with. My whole life has changed. I could have done with a huge amount of support. Much more was required than I had." Similarly, Geraldine from Wexford said, "I recovered well enough to be let home and was told after a few weeks I should make a good recovery. There was no follow-up care or information offered. It's a year later. I lost the hearing in my left ear, have trouble sleeping at night, constant ringing in my head, and short-term memory loss. I know and thank God when I think how lucky I was to survive without major complications. But just because my side effects can't be seen doesn't mean I am not suffering. I sometimes feel very alone." There is extensive research which comes to the same conclusion. Parents were concerned about after effects, with the most common request for information being about the long-term side effects and future outcomes of meningitis. The perceived effect of having more information was decreased anxiety. More information would put my mind at rest. Because meningitis is so swift and lethal, a healthcare professional's priority is saving a life, and there is much less emphasis on follow-up care and information. There is often no support offered to people when they are leaving the hospital, and they are not told or prepared for the after effects on the patient and the family. Our research shows there is a vital need for after effects information for patients and their families. This information will help to meet their ongoing needs and answer many questions during the recovery from this devastating disease. As a result, today we are looking to find a solution to the lack of after effects information given to meningitis survivors and their families. So, if you've experienced working with survivors of meningitis or providing aftercare support for other conditions, we would really like you to join our group today. Also, if you think you could come up with a new innovative information resource, we'd love to hear from you. So please do think about joining our health hack session today. We have the disease knowledge to create this new resource, but we need your support to deliver it. Thank you.
What is Angelman syndrome? Angelman syndrome is a neurological genetic disorder of chromosome 15. It's characterised by severe intellectual disability, lack of sleep, which, as Paul mentioned, is very, very cruel, sleep disturbances, lack of speech, seizures, but usually very, very happy. So who are we? We are a charity set up in 2011, and like most of the charitable groups in this room today, set up because we needed to be set up, not because we had nothing else to do with our time. Our aim is to raise awareness and understanding of this particular condition in Ireland, to create a formal network for families, caregivers and service providers, and to promote and support research into the treatment of AS. Now, while you can't cure a genetic chromosome disorder, the research is looking at the treatment of cognitive, motor and epileptic aspects in particular. So what is our problem? Well, our problem that we want to help with today is we understand and respect that doctors treat seizures and understand epilepsy, but not necessarily with Angelman at the same time. So what happens? Well, seizures occur in about 90% of people with Angelman syndrome, usually before the age of about 2. And while Angelman is not a life-limiting condition, with epilepsy, if seizures are not treated, they can sometimes be fatal. And it's often difficult to distinguish a seizure from an individual's usual behaviour. Our problem happens when somebody presents to casualty, maybe not necessarily in their own hospital or in their own GP surgery, and straight away there is a lack of information. You have a non-verbal child or adult in seizure presenting, and there's a lack of information about, first of all, the condition. What's Angelman syndrome? You can get asked, how do you spell that? Is the doctor, the neurologist there, are they aware that an Angelman EEG scan is different than maybe somebody else suffering from epilepsy? What about that patient on that day? What's the patient's medical history? What seizure medications are they currently on? And very importantly, is their pain signature obvious? Somebody with Angelman syndrome could be laughing. They could be laughing anyway, regardless of whether they have a broken leg or whether they're in seizure status. There's a lack of information about the treatment protocol. What's the neurologist's preferred drug of choice for that patient? Does the person that's treating the patient on the day in a different hospital, do they understand that? And who's authorised to change the protocol? An example we have is Connor. Connor presented very unwell to a hospital with complicated seizures. And unfortunately, his neurologist was on maternity leave and had not been replaced, and there was nobody on call. The nurse who was familiar with his file and knew him wasn't available either. So the hospital were unwilling to make any changes to his medications. So their suggestion to Mom was discharge him and take him home. Now obviously that really wasn't ideal. So the compromise was to transfer him to a second hospital where there was a neurologist on duty. And the summary of it was, Mom was told, your child is too complicated for them to treat or make changes to. So her last option was through the Angelman Network Facebook group to contact somebody in the States who obviously had experience of dealing with Angelman and epilepsy at the same time. And he very kindly was able to contact the hospital directly, the doctor directly, to suggest options and support decisions. Connor's mum's reality, in her words, were, it was the hardest few weeks and all the tears I cried, how frustrated I became. It could have been avoided if the HSE had replaced the neurologist, but more importantly, if the people who came in contact with my son had all his details. The neurology nurse understands he may be laughing, he may be smiling and hyperactive. That's just him. If I say there's a problem, there is a problem. So how could this be avoided? Well, we're asking you, if you work in this area, if you come across patients, if you treat them, what information do you need? Our parents are experts in the condition, they might be experts in the child or adult that they're caring for, but they're not medical experts. So how can we solve this problem today? We want to find a solution that all stakeholders can be supported in these acute crisis situations. What information can be connected to be made available to the health professions? And what crucial time can be saved? So we're looking for your suggestions today. Thank you for listening to us.
So my name is Mags Mallarney and I'm the founder of Move for Parkinson's, and we're passionate about educating, inspiring and empowering people with Parkinson's to manage their illness. This image shows the psychological journey a person with Parkinson's goes through. Step 1 is the diagnosis. People with Parkinson's move swiftly to step 2, shock, anger and denial. This leads them to a place I call pity park. The reality is, most people find themselves stuck in this step for a very long time, unable to accept the diagnosis or prognosis. Many never come out of this phase at all. So our problem is reaching and engaging this group of people who have lost hope and feel powerless. How do we reach and engage this group of people? Well, let me explain. The biggest unmet need of people with Parkinson's is their engagement, understanding and involvement with the illness. If they don't take an active role in managing their illness, they become increasingly isolated. Their general health declines, there's risk of falls, and will frequently require avoidable visits to the doctor and unnecessary lengthy stays in hospital. Let me share some of my own experience. But first of all, let me ask you, what was the first thing you thought about when you woke up this morning? I don't need you all to tell me, but just have a think about it. The first thing I thought was, will I be able to walk today? The second thing was, take your tablets, Mags. The next was, will I be able to move? Will my medication kick in on time? This is my morning ritual. It's different for every person with Parkinson's. Parkinson's brings with it chronic pain, temporary paralysis, which is really frightening, slowness of movement, which is frustrating, tremor, which Paul talked about, apathy and depression. Just to give you an idea, I take 25 tablets a day, spread across 5 to 6 different times, which change daily depending on my symptoms. In January 2004, I was diagnosed with Parkinson's disease. It's degenerative, incurable and progressive. I was devastated and moved into Pity Park, determined to remain there. Luckily, my positive attitude from the past and my responsibility as a mum helped me to get on the road to finding support. I looked for it in local groups but couldn't find it, so I decided to look online instead. I connected with a global network of amazing people, sharing information on the practical things they were doing that made a difference. Over the next 8 years, I worked hard to learn about my illness. I realised that just taking tablets and leaving it at that was not possible with this disease. Not if you want quality of life, and I did. The more I exercised, ate differently, managed my medication, opened myself to alternative treatments, the better I felt, and the more hope I had. The knowledge I gained gave me the insight to develop the 5 elements model for self-management that simplifies the management of Parkinson's into 5 areas. One of the symptoms of Parkinson's is becoming overwhelmed. So in designing the 5 elements, one of the key criteria was to keep it very simple. It made it easier for me to understand how to manage my symptoms, and this was the beginning of Move for Parkinson's. By far the most difficult phase of my journey was those first few months alone in Pity Park. Everyone with Parkinson's goes there. Unfortunately, very few get out. It's not surprising. Just Google Parkinson's. This is one of the first images to come up. Hardly inspiring. Not empowering. In our experience, very few newly diagnosed patients come to us looking for advice. They're too frightened. We receive phone calls from sons and daughters. It's heartbreaking to hear them talk about parents who've become apathetic, depressed, and increasingly isolated as their symptoms worsen. We share their frustration. How can we inspire and empower people with Parkinson's to take an active role in managing their condition and reconnect to the full and rich lives that await them? This is a complex problem, and it's only going to get worse if we don't address it immediately. In Ireland today, we guesstimate there are 12,000 people with Parkinson's. This figure is expected to double by 2030. If we take into account family members who are also seriously affected as they struggle to help and support their loved ones, we have a domino effect, with numbers impacted by this disease rising to 72,000. This is almost the population of Galway City. That's frightening. Thank you to IPOSI and UCD for this opportunity to present today. Over the last 6 weeks, we've had the privilege of working with Denise and Brenda from UCD and a number of other experts in the connected health field. To say that we are blown away with their enthusiasm, passion and commitment would be an understatement. We believe that the solution to this problem can be found in this room if we all work together. This is an incredible opportunity. Thank you all for your help.
I'm Jeanette Brazel. I'm the eczema patient advocate at the Irish Skin Foundation, which is a merger of the major skin charities, and we're now in formation 2 years. I was originally the founder with Caroline here of the Eczema Society, a voluntary group, and we've now merged to have a stronger voice in skincare in Ireland. So I'm here with the team today. So scratching the surface, our problem is eczema. So behind our problem is the fundamental belief that if we get to the right people at the right time with the right information, we can radically disrupt eczema care. So just a little bit about eczema. It's the most common inflammatory skin disease. There's about 20% of children under 6 in Ireland, and 1 in 12 Irish adults will suffer from it. And it can range from mild, just a basic itch, dry skin, to very severe, life-threatening, where powerful medication is often needed. And very central to all eczema is that it needs regular monitoring on a daily basis. Living with eczema, the quality of life, I know this well, and so does Caroline. It can penetrate every waking and non-waking hour. Patients and families are exhausted, emotionally, physically, and financially. There are a variety of studies over the last few years, and I think in general there's a more understanding globally of the condition. But it has huge impact right across the board in every waking hour and everything that you do as a family. Yeah, it's only eczema, we're often told that, but yet, in spite of all the information available, it is a common problem, a common disease, and it can be very frustrating to be just dismissed with it's only eczema. So, as I said before, right people, right time, right information. And if you get into this process, there is great eczema care available. There are great treatments, they're developing all the time. However, it's the if. It's a big if you get there at the right time and get the right information and see the right people. So what are the barriers to this great care? It's the nature of the beast. Eczema itself, it can be chronic and it flares unpredictably. So today you're fine or your child is fine. Tomorrow you wake up and they're in full-blown attack. You have to watch out what are the triggers and constantly chart what has been happening. The other issue is the clinical visits. They can be few and brief. Back to our problem. Access to that great care at the right time. So talk is cheap, but seeing is believing. Once you get that access, you have a very short period of time to impart an awful lot of information. It might be a 6-month consultation, and you've 6 months of charting that condition to impart verbally to your consultant. Eczema is assessed visually. The patient sees it all the time. The carer sees it some of the time, or if it's a young child, as the parent, you see it all the time. You live with it all the time. But the doctor only sees it for a fraction of the time, and maybe just for 10 minutes on a good day. So the missing link, what we're looking for, is a way to continually monitor the condition. We need something to demonstrate flares and severity over time, demonstrate the impact on quality of life, relate this information to the treatments available, and there are excellent treatments, but it has to be something available to patients, caregivers, and clinicians. Back to our problem, our big if. We're looking to you today, to technology, to disrupt this situation for us. We think that technology, as part of this process, can help deliver great eczema care. but not only great eczema care, but great personalised eczema care. And hopefully you'll come and talk to us. We have a good team here today with lots of experience in the area. Thank you very much.